what we're going to be talking about now is something that's actually quite similar to what I was talking to you before, where I was kind of mentioning more about alcohol and about general causes of liver disease. But the thing with fatty liver disease is it's still an environmentally determined disorder in much the same way that we see the problems we do with alcohol. Now, fatty liver is something which on ultrasound scans is commented on all the time. If you ever look at your patient's ultrasounds, they're often referred to as being bright. Okay, what they mean when they are referred to as bright is that the liver, which is up here on this ultrasound scan here, looks whiter than other surrounding organs, and often reference points are taken in this particular shot here of kidney. And the reason for that is that fat is reflective to the ultrasound beam. So that's a section from a biopsy from someone with fatty liver disease. And you can see actually just projected up there, it looks white because of all the fatty globules that are inside the liver. And these little globules are what is reflecting back the ultrasound beam, giving you that very bright impression. So in fact, you can, to a degree, quantify the amount of fat that you see on an ultrasound scan, because you'll see it on reports. People will either say it's mildly fatty, moderately fatty, or very fatty. And the more experienced that the ultrasonographer is, the more accurate that estimate will be. I'm going to talk to you a little bit about FibroScan later on, but those of you who've got the new FibroScan machines will know that they're called FibroScan Plus. And there's an adaptation on that which will also allow the FibroScan to estimate the amount of fat in the liver as well. So it's a single binary observation, fat there, fat not there, but there are also ways in which you can define whether there's a lot of fat or a little bit of fat. But actually in clinical practice that is not useful information. It merely confirms probably what you already suspect. Now, most causes of fat in the liver are primary fat, so this is non-alcoholic steatosis. But there are lots of secondary causes of fat in the liver, and probably the big one is alcohol. So if you look at the pattern of alcohol damage in the liver over years, the first sign of damage to the liver in someone who's drinking too much is fat. And it looks exactly the same on an ultrasound as someone in a diabetic clinic with non-alcoholic fatty liver. And even under a microscope, it's almost impossible to tease the two apart, which is interesting because it kind of suggests that the pathways of disease are very, very similar and may even be shared. So that's why the two are often hard to differentiate, okay? Because in the early stages, they look the same, and often the only way that you can be sure of the underlying cause is to take a detailed alcohol and dietary history. There are other causes of fatty liver. Now, you will come across this one quite a lot. That's TPN related. We see it a little bit less now with the modern TPN products that are used, but it's still seen quite a lot, particularly in some of the patients like we have here in Birmingham who are on lifelong TPN for a variety of reasons. This is also a common cause, but doesn't seem particularly to accelerate disease, although perhaps it does subtly, and that's genotype 3 hepatitis C causes fatty change in the liver, and on ultrasound it looks exactly like alcohol or NASH. And then there are these other rare diseases and drugs, okay? Things like methotrexate, which you'll see patients in rheumatoid clinics being put on for their arthritis, amiodarone, which you'll see in the coronary care, tamoxifen, which is still a very common drug, and sodium valproate as well, which is an anti-epileptic. So the list actually for drugs goes on and on and on. Loads of drugs cause fatty change, but these are the ones that we usually associate with it. But still, if we took 10 people with a fatty liver on ultrasound scan, probably at least 6 of them would just have benign, simple steatosis. And the other 3 or 4 would have alcoholic steatosis, and the one remaining one would have one of these rarer causes. Now, what's causing the fat in the liver? Well, we're going to look at that in a minute, but before that we have to look epidemiologically at what's causing the fat in the population, or where the fat is in the population. Now this, I think, is really scary, these next two slides. A lot of this data is actually derived from Birmingham, not very far from here, in a place called Edgbaston. And this is comparing BMI in children entering school and at year 6. Okay? And what you can see is that by year 6, 1 in 5 of them can be classified as obese. So it's not just that the older adult population of society is becoming overweight, but more worrying to us as liver doctors because it means that there's going to be a lifetime exposure to risk. We're seeing overweight children and obese children increasing in prevalence, and this is a major concern for the Children's Hospital in the centre of the city here in Birmingham. I'm sure it is in the other places that you work. And as adults, we've been getting bigger as well. And the BMI, as you all know, has been increasing over the last 10 to 20 years. And the same for most Western countries, but particularly the US and the UK. So this is the obesity prevalence in children presented a different way. Now, do you remember when I was talking about alcohol-related damage and liver disease overall, there was that association with socioeconomic deprivation? Well, this is another factor different to alcohol, which is part of the explanation for why we see that. And that is that the BMI, or the obesity prevalence here, plotted against the deprivation scale, if you look at the most deprived parts of society in socioeconomic terms, you can see that the prevalence of obesity is much, much higher than those who in the AB1 professional categories. So we're seeing a pattern, probably of behavior and lifestyle and eating habits, which is driving an increased prevalence of obesity in these groups. The challenge is that it's most difficult to intervene in terms of lifestyle behaviors in that group, mainly because they have fewer options to them in life. There's that old saying that money buys you time and choice, and it's very true actually in life. That's probably why this group here have lower levels of obesity, because their lifestyle choices are more diverse and more healthy. So eating habits have changed. Okay, it used to be 3 square meals a day. What's that saying? It said breakfast like a king, lunch like a prince, and supper like a pauper. And that actually is borne out in scientific fact as being the most healthy way to eat, and you know that as well as I do. And in the past, if you look at these yellow loops here, you can see that US children would be brought up eating 3 square meals a day in a very stable pattern of consumption. But if you move over here, okay, you can see that in US adults who are late teenagers, that disciplined eating pattern starts to break down. And if you've got teenagers, I've got teenagers, there is nearly always, I'm ashamed to say, a packet of Maltesers of one size or another somewhere on a table where homework is being done. I don't even know where the Maltesers come from, because when I go looking for them, like I did last night at 9 o'clock on a Friday, I couldn't find them. But they obviously know where they keep them. But this is what we see. Okay, so in the youngsters, we're seeing less frequent consumption times, and they're more likely to be around meal times. Once people become teens and they're more independent, they start to graze, which is what a lot of us do too, and we all know that that is a very unhealthy pattern of eating. And if you look then at the different colours here, you can see that that pattern has increased over the last 20 years. So there's a behavioural change as kids grow up and they make independent life choices. They want to eat in a more unhealthy pattern because they're teens, but also we're seeing that because of the changes that we've observed in society over the last 20 years, that behaviour has also increased in prevalence. And this is true as well. So portions are getting bigger. If you ever go into McDonald's, the first thing they say to you is do you want to make that large, yeah? Every single time, everywhere you go, do you want to make that large? I find it actually quite offensive that they ask me that, because if I wanted that, I'd have told you I wanted that. I don't want a large meal, I want a normal meal, please. But it seems to be normal. Or you go to Smith's and you're buying a bottle of water and a ham sandwich, and they say, would you like any offers? Okay, and I know, of course, that they're being monitored on that, and they have to say that to every single customer. And the offers are not apples, oranges, and pears. They're fruit chews and bars of chocolate and things that actually, yes, I really would like some of those offers, but I'm not allowed to have them. And this is a big problem because we are starting to eat bigger portions. And I like this slide because I think it shows really clearly how the size of a standard takeaway meal has increased from 1950 to present day. Of course, the other thing, which we all know, is that most people in the 1950s were much more physically active than we are today in terms of their workplace and their lifestyle and the fact that they had to use their legs instead of wheels to get around. So on two counts there, that's another reason for explaining and understanding why we have this tidal wave, really, of fatty liver disease. So your patients will tell you that they can't help it. And I don't eat anything at all, doctor. In fact, I live on air for most of the week. And we know that scientifically this can't be true. And then my daughters are completely obsessed by these hidden camera TV programs, you know, where these people who live on air are then filmed through the week. And it's amazing how dirty their air is because, you know, there's usually a kind of avalanche of takeaway chips and things that go in. But actually, they're quite instructive, those programs, because they do show what we all suspect and we know from our own behaviors as well. And that is that when we eat unhealthily, we gain weight. When we start to eat healthily, we usually lose weight. And that is a rule for the whole of society, although some patients do have slower metabolic rates, which means that it is more difficult for them to lose weight for a variety of reasons. And what you can see here is in these groups here, the obese patients are much, much more likely to consume fried food, that they're much more likely to eat takeaways, that they're much more likely to eat fried food as part of those takeaways. And we were doing, I don't think we've published it yet, we were doing a really nice little study here in Birmingham looking, using GPS monitoring, at the location of takeaways and the prevalence in Birmingham of obesity. And I know that you'll know the answer already, but the prevalence and number of takeaways is directly related in Birmingham to the areas of Birmingham that are most obese. So takeaway food, particularly fried takeaway food, and poor eating behaviours are a lot of the explanation for what we're seeing. So the government's finally cottoned onto this. It always takes about half a lifetime for any government agency to actually catch up with what's really going on. And you know, there's a big move now to tax sugary processed foods, just like there is a big move towards taxing alcoholic drinks, until the Treasury starts to get involved, and then it slows down even further because they realise that the revenues are going to fall. But there is a lot of debate and discussion about ways in which you can encourage healthy eating and discourage unhealthy eating. But still, we've got these problems. I've told you about Smith's in the hospital, but it's the same in any supermarket chain. So promotions make up 40% of take-home expenditure on food. So whether you think you're susceptible to promotions in supermarkets or not, the simple facts are the supermarket knows that you are. You are more likely to buy something that's being promoted as a bog-off or a price reduction. We call them bog-offs in our house, buy one, get one free. And you are more likely to find that the products being promoted are high sugar. So this is another example, not just now in takeaway food, but in your behaviour in the supermarket and in population behaviours in the supermarket, about how we live in what we term an obesogenic environment. So everything around us in the West conspires to make us eat unhealthily, gain weight, and become obese. And so the supermarkets, I'm afraid, are part of that problem, and that is a very simple thing, perhaps, that could be addressed, apart from this slightly awkward truth here, which is the expected revenue impact for the supermarkets. It doesn't project very well, but the M's denote millions, and it's lots of millions. So if you started to say to supermarkets that you're not allowed to promote biscuits near the checkout, and there is a very good reason why whenever we nip into Marks and Spencer's, those Percy pigs that are so addictive are right next to the blinking till, aren't they, and chocolates. The reason is that they know that that's where they're going to make a killing in terms of revenue. Sadly, they're also contributing to killings in other ways. So this is one other adult behavioural pattern. 8 and 10.5 is referring to alcohol units. But we're assuming that 8 alcohol units for a woman and 10.5 alcohol units for a man is the tipping point at which you start to think, firstly, that you could eat half of a Domino's pizza, and after 8 units in Jill's case, she thinks she can eat 2 of them, okay? Now, you wouldn't know that looking at her, but it's true. But what happens to someone's eating behaviour in the day, okay? So the same day, you start to consume 3,000 calories, so you have a high calorie consumption day. But what's really interesting is what happens the next day after you've had a big night out. And the next day, you eat unhealthily as well, okay? Because you think, I need to wake up, and your body tells you that you're hungry, and you'll have a bacon sandwich or a full English breakfast. So for somebody who goes out and has a great night out, and hopefully can remember most of it, you might end up consuming the equivalent of 6,000 calories, okay? Just on the back of excessive alcohol consumption. So forget the damage the alcohol might be doing to you. As a one-off, it probably doesn't do you too much harm, but this most definitely does, because it's going to take you a long time to shift it. And the other thing that that amount of alcohol consumption does is it changes your behaviour. You're much more likely, if you've drunk the best part of a bottle of wine, ladies, to sit down with a good film on the sofa or start going through social media sites and expending 0 calories than you are to get up and go out and sort out the garage or do something far more useful, okay? So you consume more calories on the day that you drink heavily, you consume more calories the day after you drink heavily, and your behaviours are altered by excessive alcohol consumption because you become a sofa potato, or whatever it's called. So this is the spectrum of NAFLD. Now, a normal liver, if you've ever been to a butcher shop, looks like this. It's shiny, it's smooth, it doesn't contain much fat. As you start to develop fat, and our surgeons look for this when they go out to retrieve livers, it takes on a kind of creamy yellow-orange colour. And it starts to feel different as well. And so when our surgeons go out to retrieve a liver, they look at it, but they also squeeze it, which is why FibroScan works, because an experienced surgeon can just tell from pressing it whether it's Lurpak or whether it's healthy, okay? And some of the livers that we get brought back here are spreadable. They're more like foie gras than liver, okay? Now, just having fat in the liver is not, in health terms, such a big deal. The liver's designed to have some fat, and the older you get, the more fat the liver has. It's a sign of normal aging. The trouble is here. This is where people start to get into trouble, because in some patients, approximately about 20 to 25% of patients with fat in the liver, they develop fat and inflammation. And this is the holy grail in hepatology at the moment, is knowing what the mechanism is that drives someone to go from just fat to fat and inflammation. Because it's the inflammation that starts to cause the problems. You get inflammation, and inflammation leads to fibrosis. And if you remember from one of my first slides, once you get lots and lots of scarring and fibrosis, there's no healthy liver tissue left, and you end up with cirrhosis. So in our medical clinics, what we're trying to sift is the wheat from the chaff. We're trying to work out who's got steatosis and probably needs a bit of lifestyle advice at the GPs, but doesn't need to come back to see us again, and which patients have potentially got a ticking time bomb where they've got fat and inflammation, and that is what NASH means, okay? It's non-alcoholic steato, fat, hepatitis, inflammation, okay? It's exactly what it says on the tin. It's not a clever medical term, it's just very descriptive. And we need to identify these patients because they're the ones that we really need to pour our resources into to try and prevent them from developing more serious liver diseases. Now, the bottom line with fatty liver disease is insulin resistance, which is why you see in diabetic clinics that about 35% of patients in diabetic clinics have abnormal LFTs. They probably have simple steatosis. But the mechanism for that, sure, is going to be obesity and type 2 diabetes, but also the insulin resistance that goes with that. So when you have insulin resistance, it means that your target cell, such as the lipocyte, in this particular side here, becomes resistant to normal circulating levels of insulin. So in order to get the glycemic response that the body wants, the body increases the circulating level of insulin, which is why in type 2 diabetes, as you know, patients will have high levels of insulin. The problem is that insulin is both fibrogenic, okay, in all of the research and animal models that have been done, and it also distorts the normal metabolism of the liver. And it starts to promote a drive towards fattiness, and that's the same pattern that we see in alcohol. Alcohol does exactly the same thing. It distorts the triglyceride metabolic pathway, and so you're much more likely to retain triglyceride within the liver, so you get less export of fat out of the liver, and you get more creation of fat as well, which is why in these conditions the liver starts to accumulate fat. It's making more and the fat's trapped. And the reason that that happens is because in these patients we're talking about in this lecture, they have very high levels of circulating insulin, this insulin resistance. And in the first lecture, it's because they're drinking too much, and that's having the same effect. So one of the theories that underlies this switch between simple fat and inflammation is a concept of oxidative stress. It's the same concept that we talk about in alcohol-mediated damage. There's many ways in which oxidative stress occurs, and the liver has a lower redox state, so it's more reduced in fatty liver disease and alcoholic liver disease. So you can probably understand, because I'm talking about the two together, why they look exactly the same under a microscope. Because although the injury might be different, the actual mechanism and pathway of disease is almost identical, which is why ultimately when you look at them under a microscope, they look almost identical, because they're distorting the same pathways in the body. Now the problem is when you get oxidative stress in the liver, it creates damage. It's like one of those nasty bombs that you see on the news at night, where it's not just the target that gets knocked out, it's everything around it. And it's the same here in liver, because the oxidative stress causes necrosis of hepatocytes, they die, they get broken down, they produce inflammatory products which then lead to fibrosis, inflammation, scarring, cirrhosis. So the prevalence of fat in the population in lots of studies, all listed here, is somewhere between 20 to 30%. How do you identify fatty liver in the clinic? Well, it's pretty subtle. Sometimes these patients have normal liver tests, okay? And sometimes these patients will have fatty change on ultrasound scan, but the changes in liver tests are often very, very mild. One of the truths about fatty liver disease is that most people with fatty liver disease don't die from liver disease. I know that sounds a bit weird. Most people with fatty liver disease die from heart disease, okay, or a cardiovascular death, which is why it's one of these strange things that fatty liver disease is a very powerful predictor of cardiovascular death, but it's only a minority of these patients with benign fat that will die from liver. If you look at patients who have cirrhosis, that frequency increases, but it's still a minority. Most patients with fatty liver disease are dying a cardiovascular death and not a liver death. There's also a risk if you have cirrhosis that you might develop cancer, and fat itself is carcinogenic, not just for liver cancer, but for things like bowel cancer, for breast cancer, for pretty much any solid organ cancer that you care to choose. You'll find that obesity is a risk factor for it. So there are various ways in which we can identify people with fat in the liver. We help the GPs with pathways to identify which ones we want, which ones they can keep. The treatment in the early stages is always going to be the same, which is lifestyle intervention, exercise. We use FibroScan, particularly in our hospital, but the NICE guidance, which is going to be published soon for detecting NASH or fibrosis, is going to recommend serum markers, which is probably a good thing because FibroScans are about £100,000 and you have to buy one to have it, whereas serum markers you can do in any lab, pretty much. And that's a FibroScan in action. There are certain truisms which have been demonstrated many times. That is weight loss, the effect of weight loss. Target weight loss is somewhere between 7 and 10% because at that point you seem to reduce the group in which the fatty lesion progresses and you stabilize or improve the histology in the majority of patients. So anything more than 10%, well done. But 7 to 10% is the target weight loss for somebody with fatty liver disease to prevent progression of their disease. So it's achievable, and that's a very important thing to say to patients, because they've often been defeated time after time after time in terms of weight loss. But actually, in terms of their health benefits, it's a small increment and it's achievable. There are some drugs coming. These are just really to demonstrate drugs. There's this one called obeticholic acid. You can get obeticholic acid just by chewing on a load of olive leaves, but they don't taste very nice. So this version comes in a pill. But like most pills, nothing's perfect. And so this pill will also really muck about with your lipid metabolism and your cholesterol, which in a group of patients who are most likely to die a cardiovascular death may not be a good idea. So this is going to be interesting to see where it gets. But the drug company that produced this data, the share price, I think, quadrupled overnight when the early data was released. In Birmingham, we're really interested in GLP-1 analogues, Liraglutide. Most of you will have seen that in your diabetic patients. It works in diabetics and non-diabetics as well. And certainly in the trial that Phil was the chief investigator of, it yielded a positive endpoint in terms of histological benefits. So for a drug which many patients could be on anyway because of their diabetes, we're kind of promoting that more. The downside of it is an injection, okay? And some patients don't like that. So lots of things are emerging. It's a huge source of investment for the pharmaceutical industry for obvious reasons. Some things don't work so well. There's things like omega-3 fatty acids, metformin, ursodeoxycholic acid. I have to say, for a lot of my simple steatotic patients, I still use a lot of metformin because it promotes weight loss. It's a bit of a cheat, but it's a cheat's way of doing it. And I still do suggest that they take omega-3 fatty acids because there is some data to suggest that it reduces fat, but it doesn't have the data to say that it prevents progression of the disease. Okay, so as long as you know what you're using it for. So NASH is common, but only a small proportion of patients with NASH will develop liver disease, okay? So most patients with fatty liver are going to die from a heart attack or a stroke or some other cardiovascular mechanism. The interventions are simple. They're lifestyle, they're exercise, 30 minutes 3 times a week. They're 7 to 10% weight loss, things which are achievable and doable. One trick that I do, I always tell my patients to go out and buy an activity monitor. I quite like the Jawbone ones because they're really simple, they're quite cheap now. 10,000 steps a day, okay? And the patients really like it because it's simple, they can wear it, and it actually shows them very clearly whether they're couch potato or active, and it does seem to have a benefit. The pathogenesis is not fully understood, but you can understand now that the core seems to be this idea of insulin resistance. And the management, there is going to be some drug development in the next few years for some patients, highly selected, probably in hospital clinics. But the bottom line is it boils down to lifestyle change, eating behaviors, and diet, which is what you do. Thank you very much.